Hello, everyone. Welcome to the webinar. We are just going to give people a second to join, and we're really excited to be with you today. I'm trying to show this slide. Sorry. So thanks for joining us. We'll start in just a moment. And welcome to Healing Communities to Heal the World. Our session today is on healing after healthcare crises. Okay, I think we can go ahead and get started. So we're going to start today with a land acknowledgement, and Dr. Pedro Flores is going to lead us through that.
Thank you, Kihara. I hope you can hear me okay. Good morning, good afternoon, everybody. I'm joining from Southern California. So here at the campus of the University of San Diego, we carry the footsteps of millennia of the Kumeyaay people. This land is part of a relationship that is nourished, healed, protected, and embraced the Kumeyaay to the present day. The campus at the University of Vermont sits within a place of gathering and exchange shaped by water and stewarded by ongoing generations of indigenous peoples, in particular the Western Abenaki. Finally, the campus at Rush University is situated in the ancestral homelands of the Peoria, Miami, Kickapoo, and Potawatomi nations. These lands and these waters were the traditional territory of these native nations prior to their forced removal. The descendants of these nations live on today, carrying the stories of their struggles for survival and identity. For many of them, profound healthcare inequities are the burden they continue to bear, manifesting in disparities in access to healthcare, higher rates of chronic illness, and a lack of culturally competent health services. As we gather today, we must recognize that an acknowledgement alone is not enough. May we strive to dismantle systemic inequities and advocate for the rights of Indigenous peoples, prioritizing their healthcare and well-being. In this spirit, I invite each of us to reflect on our individual and collective roles in fostering reconciliation, healing, and justice. Together, we can create a future that honors the past and uplifts the voices of those who have historically been silenced. Thank you.
Thank you, Pedro. Welcome, everyone, to Healing After Healthcare Crises. I'm Kihara Morvising. I'm Director of the Center for Justice Reform at Vermont Law and Graduate School, and we have two wonderful speakers for you today who I'm going to introduce in just a moment. I wanted to just share with everyone the origin of this series. Basically, as director of our restorative justice program, I started thinking to myself, how do hurt communities heal? And I wanted to know, I'm looking at communities who experience trauma through a range of factors, through community violence, environmental disasters, health crises. And we know that our communities also have histories of harm through unjust systems like racism, economic inequality, the treatment of Indigenous people, sexism. And so the question for me is, how do we help communities heal from these traumatic events, and how do we move on from hurtful histories, and what is really working out there? We talk a lot about healing, but do we know what actually moves the dial and helps people move forward? So we're going to be doing this series throughout 2025 to explore these questions. Each time we present, we'll have a different topic. So in our last session, we explored healing after environmental crises, and we'll have that available on video if people are interested. But today we're focusing on healthcare. So to say a little bit more about our session today, We'll explore both healing after the COVID-19 pandemic, which is the most major healthcare crisis most of us have experienced in our lifetime. But we're also going to explore how people heal after difficult interactions with the healthcare system, and also how healthcare providers themselves practice healing after traumatic events, like taking care of people and seeing losses and healthcare crises. So I think it's going to be a really interesting conversation. Before I share bios, just to tell you a little bit about the format for today, what I'd like to do is to introduce our panelists, Dr. Timothy Gallagher and Dr. Pedro Flores. They will be chatting with me about some of these ideas and issues, but you all are welcome to put questions in the chat as we speak. And then the last 15 or 20 minutes or so of the conversation, we'll open it up to questions from the group so that you can, share some of your questions. The way to share questions is to type it first into the chat. But if I select your question, I'll invite you to go on camera and unmute if you'd like to interact with our speakers. If you're shy, you can also stay off camera. That's okay as well. Let me tell you a little bit about our amazing speakers for today. So Dr. Pedro Flores, which on my screen is on the right, is a clinician, a professor, and a restorative justice practitioner. So he owns and operates Therapy Professionals, a physical medicine and rehabilitation practice in California. And he also works as a professor and restorative justice trainer at the Center for Restorative Justice at the University of San Diego, which is where he obtained his PhD in this subject. Dr. Flores has worn a range of hats in healthcare over the past 25 years, including working as a clinician and administrator. As a restorative leader, he is particularly interested in interpersonal relationships between clinicians, as well as creating equitable spaces where patients, healthcare providers, and others can collaborate together on shared issues of concern. Dr. Flores is actually currently writing a book about restorative practices in healthcare and claims his life mission is to create restorative doctors and restorative healthcare professionals, which I think is very cool. And I want to also introduce our next panelist, which is on the left of my screen, Dr. Timothy Gallagher. So Dr. Timothy Gallagher is an emergency physician based currently at Rush University Medical Center in Chicago. He is also the founder of and director of the Rush University Health Equity Fellowship and an assistant professor at Rush University School of Medicine, where he teaches the Health Equity and Social Justice Leadership Program. Dr. Gallagher worked as an emergency medicine physician at 2 hospitals in New York at the height of the COVID-19 pandemic, New York University and Bellevue hospitals. He has conducted research on COVID's impact on the unmet social needs of emergency department patients and on patients' perception of available social services. He also published an essay called The Practice of Touch with Sun Magazine about working as being both the father of a young child and an emergency medicine physician during the intersection of events of 2020, such as the COVID-19 pandemic and Black Lives Matter movement in New York. So we're very pleased to have both of these panelists with us today. I also want to commend them for working in healthcare during some of the most difficult years to work in healthcare of our time. I view you as true heroes and really thank you for your service and care of so many people. So I wanted to move us into some questions. So first question, a little bit of a on-ramp to this question, and then I will stop talking and hear from our panelists. We often think of healing in healthcare as related to healing of the body or healing of the mind. Today, we're really talking about healing in a more philosophical sense. So how people heal due to impacts of healthcare crises or due to negative experiences with the healthcare system. So today, what we're really going to be exploring is the need for healing in a broader sense in the health space, not that sort of traditional way that we associate healing when we hear that word healthcare. So we want to look first to our most recent health crisis, COVID-19, which, as we know, profoundly affected us all, but deeply affected certain communities. COVID-19 also had huge effects on healthcare professionals working during that time. And I think people are still healing from things like seeing people they love die or witnessing many deaths in their community. One could also argue that there was a lot of harm that occurred during COVID-19, including governments and businesses not acting quickly enough, employers pushing employees to work in unsafe conditions, and racial and economic disparities that affected resources. Plus, as healthcare professionals, you still may be processing stress and sadness from that time period. So I wanted to talk a little bit about the harms that you saw during COVID-19, and what needs you saw for healing right after the pandemic, and what needs you're seeing for healing still now. So let's explore sort of this harm and healing dynamic a little bit. So I'd love to start with Tim, and as I said, can just kind of be a free flowing conversation. But Dr. Tim Gallagher, you were working in New York at the time of COVID. Could you tell us a little bit more about your thoughts on this?
Yeah, first, thank you for inviting me to this. I think it's a really important topic, and I'm honored and humbled that Quijada asked me to be here. I think I will forever have imposter syndrome, so I'm flattered that I was asked to do this as well. I grew up in Maine, and my brother went to school at Middlebury, so I have a strong kinship with Vermont as well. So I'm happy to be, at least virtually, with you all there. Like Quijada said, I am an emergency medicine doctor, and I was working in New York City at Bellevue Hospital and NYU during the height of COVID. Just to orient you, for those of you who don't know, at least in the emergency department, the same doctors work at Bellevue, which is like the flagship public hospital of Manhattan, and at NYU, which is a tertiary care center, private, very wealthy hospital. And they are quite literally, in the real sense of the word, one block away from each other. So you can just walk between them, and unfortunately a world apart. The people that come into Bellevue are largely minoritized in many different ways, socioeconomically depressed, and marginalized because of that in so many ways. And unfortunately, going through the public hospital system, they just don't have the resources. I, as a doctor working there, do not have the resources to care for them in the same way that I care for my patients at NYU, which is a block away, and a tertiary private hospital. Which is a whole thing to unpack. If that's where the direction goes of this conversation, I'm happy to talk about that. That's just to set the scene. And COVID was scary. I was in the emergency room, and I trained as an emergency doctor, and part of my training is working in the ICU, intensive care units. So I'm no stranger to having patients die, and it's hard every time. But I was not prepared for the overwhelming death of COVID-19. My emergency department turned into an ICU. There were ventilators everywhere. There were power cords and ventilator cords draped from the ceilings, taped to walls. It was just, we were structurally not prepared for this. And I had patients die on me often. And it was very hard in terms of volume, and in terms of my training kind of prepared me for patients dying in a more predictable way. And this upended that. There were patients that were younger and that didn't have the existing medical problems. So it was a very stressful time emotionally to see that. And I think for the purposes of this conversation, some of the things I would highlight as the hardest parts, one was just like the change of communication and physical touch during that time. As you know, we were quarantining, which was, I think, a smart move because we had to stop the spread of disease. But it also meant that I was completely donned in protective gear and working on patients I could not have the typical physical contact with and typical eye contact with that I was used to. And even when my patients were with me and dying, they could not have family members come in with them. So I was forced to get family members on telephones and talk to their loved ones virtually. So I think one big harm from this is the loss of physical touch and typical modes of communication that we are used to. And I think we can get that back now. I think it may happen again if we have to quarantine again, and hopefully we learn from it. But it is something that I think would be good to unpack here, because I think the social media and virtual world has a lot of attributes. Certainly we are at different parts of the country right now having this conversation, but I want to make sure that we don't lose the balance of the importance of physical touch and being with each other and having a more traditionally rooted sense of community. So that was one big problem or hardship living through this. And another kind of goes out from different levels. That was my personal experience with it. My professional experience was working at a hospital in which political forces unfortunately took over medical wisdom. And so we were at a point that we were about to have to ration ventilators, which are the breathing machines that many people required. And there's only so many, and there's only so many people that can work those machines. And so at some point, either you just use them all up and you just don't have any more, or you ration them out in a more thoughtful way. And unfortunately, because my hospital system did not want to be considered a death panel or have weighed in on that, they did not weigh in an official way to say who should get ventilators and who should not. And that was very hard for me because the official language from my hospital was, oh, we got your back. You make the decision, we got your back, which is okay, reassuring, but it's like highly unethical because we know that from the management, I'm supposed to be focused on my patient in front of me. I'm not supposed to be focused on the population of patients around me. And so I should always be advocating for my patient to get to the ventilator, even though if I were to take a step back, it should go to other people. And so there's supposed to be a panel that's not the clinician involved that decides this. So on a hospital level, it was difficult. And then on a more societal level, it was devastating. As I'm sure you all are aware and has come out, it really just exposed the structural racism, structural problems that the whole country is dealing with and the whole healthcare system is dealing with. Our healthcare system is racist. And it really was, COVID was not the straw, that was the boulder on the camel's back that really just exposed all these pre-existing problems of people with vast inequities in access to healthcare and in lifestyle unmet social needs. And I did some research showing that not only is this country underprepared to help people with these unmet social needs to begin with, the people that could access the care that does exist don't know that they can access this care and don't know how to access this care. And then COVID-19 dumped a whole nother population into that need group of people that needed it. So it further stressed a system that was already stressed and put more people in that did not know how to navigate the system and were not communicated to in a way that allowed them to understand the system. So unfortunately, it's a lot to unpack, but I felt it on like a very personal level, like a work level and a societal level. So it was a difficult time to go through, and I'm happy to speak more to those or unpack those, but I feel like I just opened a can of worms. So I want to make sure that everyone has a chance to pick apart what is interesting to them.
You opened up a good can of worms, and we're grateful for your work during the pandemic and ever since, and grateful for your contributions, Tim. So thank you for starting us off on such a good note. One of the things that resonated with me with what you said had to do with what these inequities and living between these two different worlds, and even though they were only literally a block apart. And the resource allocation part that you were talking about, and hospitals not being prepared through not having crisis standards of care that are equitable. And in 2022, Dr. Ruby Long and I, along with other restorative justice practitioners and emergency medicine doctors, wrote a paper, and it's about community engagement in order to inform crisis standards of care. And the idea here, going back to Quijada's point about what does healing mean in the context of all of this type of harm? Well, what healing means is engaging the communities that are most vulnerable and at the highest risk of the next pandemic. So healing for me would represent how do we engage those communities right now and not wait until the next health crises in order to engage them and educate them, like you said, give them access to resources, but most importantly, enter that conversation with a degree of humility to be able to understand what they actually need. Early on during the pandemic, a lot of lower socioeconomic, minoritized individuals, Black, brown individuals, were forced to go to work. This is before we were a mask mandate. This is why so many of them were exposed to COVID-19, where so many of us worked from home or worked remotely, right? So this is an example of like how we could start to transform systems so that the next time something like this happens, we are much more prepared as a community, as a nation, at the federal level, at the hospital level, to provide resources based on the needs of each demographic. I teach healthcare leadership, and unfortunately, we all know the statistics. For being such a wealthy country and having the best trained physicians and the access to pharmaceuticals and technology, our healthcare outcomes are really poor. And I always remind people that it largely depends on what zip code you live in. Our healthcare is fabulous. It's fantastic if you have ventilators. It's fantastic if you have access to healthcare providers and skilled labor. But if you don't, then it actually plummets severely. So we touched on a lot of things, but one of the ways in which we could help is to engage the community. And that requires giving them a level of power and sharing power so that we elevate their voices and we understand what they need. That's how we can truly design a healthcare system that is equitable for all.
I find that just such a fascinating point, Pedro, and I'm curious if we could unpack that a little bit. So my background is also in community engagement. I'm wondering, like, what does that look like exactly? You know, if either of you have actually included, you know, vulnerable populations or community members in trying to think about, you know, how to do healthcare better. I'm just kind of using a broad frame there. Like, what would that actually look like if we had examples? I'd love to sort of visualize it a little more.
Yeah, I totally agree with what. Oh, sorry.
No, you go, Tim. Thank you.
What Pedro was saying is, to me, it comes down to honesty and agency. You need to be, and at different levels again. So I need to be honest and give my patients agency when it's me one-on-one with a patient. I need to explain to them that healthcare is not black and white. Sometimes there's not a right answer or a wrong answer, and give them my information, my standpoint, my advice, have them ask me questions, and then have a conversation with the patient about what is going to work best for their care in the real world, not some statistical knowledge that I know that certain things will help certain people, but like, what are you feeling? What's going to help you? And then to kind of bring that out. Thankfully, I work at an institution that is right now doubling down on their DEI efforts and language. And we just had, every 3 years, we have a community needs assessment. We go to a bunch of communities and send out surveys, and then have actually just like long qualitative interviews with hundreds of patients in our communities to really not just look at the numbers, but to hear the stories of what people who are the people that need help from an institution like a healthcare institution, what they view the help as and what they view the barriers as. And in hopes to give these people agency to come down from this ivory tower of mistrust and of dogmatic kind of paternalism into a dialogue to see not what's working in a medical book that I read from 20 years ago, but what is working on the ground and what people need on the ground. So I think it's honesty that this is like a murky area, and it's an area that has a lot of feelings involved and a lot of gray area involved, and also agency to really work with each other on this. Because I think one of the biggest tragedies that came out of COVID is just the vast mistrust and the kind of tribe over truth sort of sway that we had. And it's going to be hard to win that back. And it's sad. I kind of envisioned, like, when we're kind of entering into COVID, I envisioned like this very like almost sci-fi, like, yeah, this is like the aliens coming down. We're going to band together as people and we're all going to understand our similarities. But instead it kind of really siloed us and brought out our differences. So it was pretty tragic in that sense. And I have some thoughts of how to bridge it together, but that's where I see the crux of things happening.
Thank you, Tim. I've had the luxury of being able to convene community members in circle and restorative circle practices. Just for context, the clinic that I own and operate, we do cardiopulmonary rehab. So it's an outpatient clinic. So during the pandemic, I was in Southern California running 2 or 3 clinics. My patients were the highest vulnerability in that they have cardiopulmonary disease and a lot of comorbidities, so they're at the highest risk level for COVID. But where I live, a lot of our patients are socioeconomically stable. So one of the issues that I was dealing with is the moral distress and the ethical dilemma that I am a respiratory therapist. I can manage ventilators. I know how to help acute healthcare systems, and I was experiencing a level of distress of like, am I helping the right community right now? And I felt stuck because I didn't know what to do. I severely wanted to go to the high need areas of the country to offer my support, and yet I was trying to keep my patients safe. In that same breath, I might see one of my patients on a Friday and lose them by Monday because they had gotten COVID and were at such a high risk for this disease that they passed away over the weekend. And that's something I had never seen in my practice before. So what we started doing was convening circles when it was safe to do that to help them process the issues. One of the things that became very apparent to me, it was really sad because there was a generational problem that I was experiencing, and also a socioeconomic problem. A lot of our patients, because of their disability, because of their income, because of their psychosocial conditions, could not rush to Costco to buy toilet paper and tear down all of the, go down every row of the grocery store and hoard all of the things that they needed in order to stay afloat. And that was really hard for me to witness. It was hard for me to experience as a middle class male in this society, seeing my community do that, and then seeing the perspective of my patients who didn't have access to that, who couldn't compete. So that just gave me a little bit more context and awareness of what it then must be like for someone that is low socioeconomic status, has to take a bus to try to go fill a prescription, to try to go pick up groceries, and not have the education and resources that they need. And so I think for me, going back to the question, Quijada, community engagement is creating opportunities, whether they be outside of an emergency room department, with regards to public health efforts, to be able to allow these individuals to process their experiences and start rebuilding trust. In restorative practices, we have a sort of a three-step framework, which is similar to the medical model. And phase one is really listening for understanding. And that is about building trust and building relationships. And Tim, you talked about how we've lost trust. We've lost this fiduciary relationship that we have between the patient and the healthcare system. The next step, after understanding what's actually happening with the community, is planning and doing. And this is inclusive decision making. This is knowledge that's informed by our stakeholders, our patients, and that varies from zip code to zip code, from block to block. And finally, the next step is devising strategies to help support them based on their needs, and then studying them. What were the outcomes? How do we adapt the system in order to continue meeting their needs, and then reporting out the findings? That's a restorative framework that matches our quality improvement models in healthcare, what is known as Plan, Do, Study, Act. But it really begins with relationship building, and it begins with starting to rebuild trust.
Yeah,
I think that's
I'm
brilliant. I just
thinking,
want to,
yeah, please go ahead. Yeah.
I think that's so smart. And I want to pick up on one thing that you said that I've been mulling over lately. You said listening to understand, or listening leading to understanding. Because one problem that I identify is that we're in these silos. We kind of honed in on what our community is. So our community is like this safe space of mostly like-minded people. And I think the restorative step that we need to take is to bridge out from that, to branch out from that, and to talk to people that are in our entire community, not just people that we necessarily agree with or feel comfortable with. And in doing that, I think it's important for us to keep the mindset, the listening mindset, in that it's easy to enter that to someone that I don't agree with as like a debate, like, oh, I'm going to convince them that I'm right, that I have these facts, and then they'll come around to my mindset. And that is just, I think, not the restorative or the correct way of entering that dialogue. And instead to kind of be open to listen to their lived history and to their experiences, and understand where they're coming from and why they've chosen to have the ideas and thoughts and outlook that they have. And similarly, explain yours. And you don't need to agree at the end of it, but it's important to humanize the process that the other person went through in order to kind of gain that empathy, to then move on to the next steps of coming to some healing and bridging of the communities. And you don't have to agree 100%, but I think having that more open mindset allows you to understand the Venn diagram crossover of your beliefs that probably does exist, even if you don't see it at first, because we're all kind of charged into our own silos. So it's just kind of taking a step back and understanding that it's not a debate to win or lose, but a path to understanding, or a way to understand other people's paths to where they are.
Yeah, I think this happens so commonly in so many of our systems where the sort of professional experts, right? In this case, doctors, healthcare administrators are often setting policy and setting practice, but there's not necessarily inclusion of the people affected by the system. And so it reminds me, this is a someone in the chat had mentioned the disability community earlier, and this reminds me of an adage that came from the disability community: nothing about us without us, right? That it really is important, I think, for these sort of two-way conversations, because people's experience with the healthcare system is not something that the doctors know necessarily, right? Because you're coming from a different place, and so I think that can be really, really helpful. I love how much we've talked about community engagement. I'm curious, there's some other levels of harm that you both identified when we were talking at the beginning. And before we open up the Q&A to the general group, I'm kind of curious in hearing a little bit about what work needs to be done around healing and some of these other areas. So I think we've talked a lot about disparity and allocation of resources. But there were some other impacts that it might be interesting to explore. So one, Timothy, you identified was the kind of coldness of medical professionals, not intentionally, right? But because, health wise, you had to sort of put some limits on that to protect public health. But, there may be people who had an experience where they said goodbye to a loved one on the telephone and then never heard from that doctor again, and they're still sitting with that and remembering that, right? So that, I think that's kind of one example. Pedro, I know that we've also talked about in a pre-conversation to this dialogue, we talked about how sometimes you're seeing medical professionals themselves have interpersonal issues, or maybe still be carrying some trauma from experiences like COVID that are sort of affecting their work. So those are two examples, but there may be other work to do as well. But what I'd be curious to hear from both of you, like, what is the work that we need to do to help heal our healthcare system, especially considering like the monumental thing that we've just been through. I mean, it's been 5 years since this started, right? It really is still in the very recent past, and for some people who are immune compromised, this is still in the present, right? So I'm just kind of curious, what's the work we still need to do, and how do we do it?
I'd like to begin by just sharing some statistics that I think might help us. By 2021, 2022, we had lost about 20% of the healthcare workforce. They had left the healthcare field to go pursue other careers. At present, about 68% of nurses meet the criteria for emotional exhaustion, burnout, and depersonalization. Over 50% of US physicians are experiencing burnout, and resident physicians are especially vulnerable. It's predicted that by this year, the global healthcare workforce would have left the field and gone on to do other things. So we're experiencing this paradox of healthcare workers that are experiencing vicarious harm and trauma, are emotionally and physically withdrawing from the field, are becoming depersonalized and numb, and don't have enough support and resources because people are leaving the field. And at the same time, there is a call and an imperative for empathy and for active listening and caring and healing other people. I think one of the ways it begins is by healing the healers. A lot of the work that I end up doing as a consultant is going to healthcare communities that are fractured, where they're not communicating well, they're mistreating each other. We experience this phenomenon where we harm each other in order to heal our patients. That is, I wrote a dissertation called When First Do No Harm Fails. How do we address the harm that happens between healthcare providers in the act of healing others? And I think that's where it begins. We've started to make strides in medical education, and creating opportunities for healthcare providers to process their own experiences and support one another. I think the healthcare system has long been waiting for some hero in an administrator's with an administrator's cape to come in, fly into their departments and acknowledge them and let them know that they're seen and appreciated. But the truth is, we can start healing one another and supporting each other better and naming these harms and recognizing that it's part of a system and that there are downward pressures being placed on healthcare providers that force us to treat each other this way. And the restorative way of moving forward is to recognize that and be there for one another and support one another. I think we need to do that just as much as we need to focus on community engagement, because if we just focus on one, the other will still be creating harm or harmful experiences for patients. Tim, I would love to hear your perspective on this.
I'm not sure if I can add too much. That was very eloquent, and such a good perspective. The things that it makes me think about are just, I feel like I'm harping back on this, but like I'm just seeing silos again in that in the interpersonal relationships between healthcare providers. I am trying to change this with my own fellowship, but throughout my whole training as a med student, as a resident, I had no, to be a physician, I had no classes or hands-on experiences that also involved social workers or nurses or respiratory therapists. And so like, it seems that certainly in healthcare, and I imagine in higher education elsewhere, there's all these unnecessary silos. And so I think just having lenses to see those and see how breaking down those or bridging those could help, because then you would have the empathy of the nurse you're working with or the physical therapist you're working with. So I think that's one thing to be aware of, not just in healthcare, but for everyone that's listening, kind of as you go through your professional path, to see what divisions exist and why, and do they need to exist, and try to break those down. And the other thing that made me think about is really something that was hard for me to do, is just understand that when you're in this work of justice and advocacy, you need to have a balance, and you're not going to be your best person every day. So you need to cut yourself some slack. But you also need a balance of like when you're able emotionally and time-wise to chew on the big things, and when you need to chew on the small things. So I've done a lot of research, as has Pedro, and I'm sure a lot of you kind of have these bigger academic things that you chew on, which are great, but then you need to balance it out with real world things to make sure that you're feeding your soul and that you're not detached from why you're doing this. And as an example, as I was doing some of my research on the inequities of social services to people in New York, I bike to and from work, and so I would bicycle home, and one of the places where my bike past was where one of my undomiciled patients often was. And she was an older trans female that could not afford anything to look female. And so she was very phenotypically male and suffered from that. She also suffered from schizophrenia. She had HIV. She had a lot of things that were hard for her. But one thing that like actually helped me, I think just as much as helped her, is every few times I would just stop and talk to her on the side of the road as I was passing by, to see if she was feeling okay, to see if she had the food she needed, to see if she had a fever and she needed to be directed to the hospital. So it's just, and I don't know if that was more for her or for me, but just to understand that there's a balance that you need to do to like make sure you're nurturing yourself and make sure that you're connected to like a very real world, tangible, small things, even as you're tackling big things. And so I think the imbalance of that sometimes makes us feel defensive and anxious, and leads to these problems of burnout and interprofessional strife.
Yeah, I want to go back to just the pathology of what you just described, Tim. And you used the term patriarchal earlier today. And I think the medical field has largely been this evidence-based, if it's not this randomized controlled trial, this prospective randomized controlled trial, and I don't have this gold standard. That is how we agree in medicine that we can all agree on what's best for our patient or a patient population. And the problem with that is that there's a lot of doctors and a lot of specialists all arguing their case and making cases in order to gain compliance from others. And what it does, it actually fractures and it creates a wall between providers, and it gets in the way of relationships and problem solving and creativity. And how do you provide care that's culturally, appropriate for a patient or sensitive to their needs? That requires a level of giving up some power and control, which is something we're not used to. That makes healthcare providers feel very vulnerable. Whenever I lead a restorative circle with healthcare providers, first off, I'm a researcher, so I have stats, and I know that our community needs statistics. So early on in any type of presentation, I start spilling out a bunch of data in order to gain their trust. But I use vulnerability as this bad word in healthcare. Vulnerability is likened to weakness, to gullibility, to exposing yourself and exposing your weaknesses. And so for healthcare providers, getting them to a space where they're willing to be vulnerable and open and say, I don't know what the solution is. With COVID, we did not have solutions. There's this term that the military uses called VUCA. Have you all heard of that? It just represents varying dynamics of social problems, and it stands for volatile, uncertain, complex, or ambiguous. When we have problems that are VUCA problems, like COVID-19, where there's no checkbox that can solve it, what it requires is vulnerability, humility, and an openness to hear other people's perspectives. Again, putting the finger on the pulse of what the community needs in that moment and what they're experiencing, because we don't know what we don't know. And so that requires a level of humility. And that's something our profession is not used to.
I'm gonna that's a tough comment to switch the subject on because it's so rich and we could talk about that for another hour, Pedro, but I want to make some space for some of our participants to ask you some questions. So let's continue the conversation in that context. The first question, I'm actually going to invite you, Beulah Early, if you'd like to unmute and go on camera so we can see you. You're welcome to. You also don't have to. But Beulah asked, I was wondering if you have seen community-based or community-led initiatives contribute to the healing process in heavily impacted communities. So I'm not sure if you've seen any examples of that or not, but interesting question. And either of you can take it.
May I have, and I think one thing to remember in this context is to really expand on what you see as your community. And one thing I know these conversations are happening, and one thing that I try to do as a healthcare educator is bring my students into a sphere that's tangential or may not seem as directly connected. So through the med student program that I teach, we go to a homeless shelter, we go to a disabled persons advocacy group and hear about their perspective. We go to something called the Chicago Torture Justice Center for exonerated people that have been beaten into false confessions, and all of which is to say that these conversations are happening, and it's just important for you to I think it's important for me, I think, to understand that going to a different community has value, not just in hearing that community, but in hearing how that can tie back to you, even if it does seem pretty attenuated or tangential. So we take our med students to these places that are pretty indirectly associated with healthcare until you dig down and hear the stories and hear how the whole community's health is affected by wrongful imprisonment or something. So they have a distrust in not just the political system, but also in hierarchical systems in general. So they have a mistrust in healthcare system. And I think it's important to, when you're seeking out these dialogues in other communities, to really listen and reflect and bring it back, have it feed yourself as well.
Thank you, Tim. A couple of examples, in addition to the circles that I've led with my own community, which was not a high impact community. I've done some work with the San Diego Department of Health and Human Services Agency to train their nurses, their therapists, their social workers, their doctors on restorative practices to start having circle practices with their community. At the University of Rochester, we did a series called The Anatomy of Hate. And this was really about racial literacy and healthcare equity, and creating spaces where resident physicians, nurses, doctors could come together and talk about redesigning a healthcare system that's equitable for minoritized and highly vulnerable patients. And then what we're doing now that I train medical schools in restorative practices, is we're teaching medical students about this discipline, but not to just look at it as a form of justice or a relational approach to having a difficult conversation with the patient, but as a way of approaching. They do a lot of community-facing, community-oriented work. So incorporating circle practices as a way of engaging the community as part of what it means to learn medicine.
Thank you both. I'm sorry, Beulah, I think I am learning through this that you'll have to raise your hand if you want to be unmuted, and then we're able to do that. So sorry that we weren't able to do that for your question, but we really appreciate the question. I'm gonna paraphrase a question from Maggie Chavez, but Maggie, if you want to come on camera, you're welcome to elaborate on your question. But I think Maggie is one of our students, and she's interested in basically people who are double affected. So I'm going to paraphrase your question a little bit, Maggie, but I think there's a curiosity in individuals who may be involved with the criminal justice system and also needing healthcare, and how that might play out. Maggie, I know your question was more about rural communities. I think I'm not, I know Pedro and Tim work more in urban context. I'm not sure if they'll be able to speak to that or not. But is there anything else you kind of want to say about your question to clarify?
Yes, also hello, and Kyle Gloverstein here with me. We're calling from Rogers House, the home of the NCOJOR, so calling from Rogers House. Thank you again, guys, for taking time. This has been fantastic, and I can't wait to watch this over again and send this information out. This has been great. So I was paralegal with the Public Defender's Office in Clovis and Portales, which is 9th Judicial District, the other side of the state from where the Navajo Nation is. So I think broadly, I could see where a lot of the impact was coming from when it came to the lack of resources. Navajo Nation suffered some tremendous issues and losses, and in some aspect, a lot of the resources from my area were sent over there, so there was a lack in my area as well. I know you guys are more from urban settings, but did you also run into the issue where the persons who are incarcerated in our area, which is very, very high, I want to say our per capita in the county around that time at the height of COVID was about 670. And there is a population in those counties total of maybe 60,000 people. So it's very, very high rate of incarceration. But with our clients, they were also having some issues with getting access to information because we don't have a whole lot of hospitals. They weren't able to access the care that they need. And then for those who were incarcerated, we were having a hard time with compassionate release or other measures like that. So are those things that you also ran into or had experience with?
Like that, we're both thinking here.
I ask the hard questions. You can talk to Bobby and JV about that.
I personally, first off, happy Friday, Margarita. Pleasure to meet you. Thank you. I have not personally had that type of experience, but what came to mind as you were speaking for me was what it means to heal Indigenous communities and how to build equity around culturally sustaining practices. I do a lot of work in Canada. I work at the University of British Columbia and at the University of Manitoba. The University of Manitoba and Winnipeg in general has a higher population of Indigenous people. And they really, what Canada has done, which I think is important for your question, is their Truth and Reconciliation Commission actually created an action plan centered around healthcare equity and incorporating healing practices that are culturally relevant to Indigenous communities and embedding that into the medical model and creating opportunities for that to exist. So I cannot speak to the impact or the overlap of incarceration and resource allocation as it relates to COVID. That was not my experience and my practice, but I can tell you that a lot of work has been done in Canada around truth and reconciliation and healing practices and embedding that into the practice of medicine, not only to diversify medicine or the practice of medicine, but to actually create equitable and adjust for the healthcare inequities and healthcare disparities in the Canadian healthcare system.
Thank you. Lisa, Pepe, I'm going to invite you to ask your question on malpractice. I think you should be able to speak if you'd like to. If you just try to unmute your camera and put yourself on video, I think it should work. And maybe it's not. Brian, is there anything we can do to help Lisa?
Looks like Lisa left.
Okay, I guess Lisa had to go. Well, this is a question that I think is interesting and kind of a bringing us closer to the close, although we may have time for another couple questions. But Professor Sand asked a question about what the lessons learned are for the medical school education from the pandemic. Professor Sand, I'm going to allow you to come on if you want to. You should be able to.
Thanks. This has been absolutely fascinating. So Kiara actually pretty much said my question. I'm curious what the lessons learned are for medical education as a result of the pandemic. Because I have a sneaking suspicion some of the lessons learned might carry over for legal education as well.
I think there are a bunch of lessons learned. I think first and foremost is to understand that this is not historical. We're going to have another pandemic. And just to make sure that we have a dialogue and empower medical students to think about things differently and empower them to share from their perspective what is their fresh perspective on the medical system and presumably law students on the legal system of what the entrenched problems are that it is harder for me to see that someone who has gone through the system already, and to really be open to that, which is difficult as a teacher to be open to these new ideas as a student. But I think that's one of the most powerful things that we can do to understand that this is not a one-time event, one-time pandemic. We need to really learn from this and change our structures accordingly. And just like I said earlier, one of the big structural changes that I see is really breaking down some of these unnecessary silos that exist certainly in healthcare, but in all academia as well. And just like the very hierarchical nature of it, there seems to be a very big, like, you know, I suffered through this system, therefore you need to suffer through the system to be a good X attorney, doctor, or whatever, without fully analyzing, is that a healthy way to learn this? Does the structure itself need to be changed? And I think having our ears tuned into the fresh voices that are seeing this from an outside, now inside perspective is a really important step for us to take in terms of our relationship with the medical students or law students or professional students.
Thank you, Tim. I'll just piggyback and say that one of the things that happened, I work with a lot of medical students and I was working with them during the pandemic, and this social isolation and this disconnectedness, this lack of community was actually very difficult on their psychology. Meeting emotional needs and the need for relationships and being in community. Medical school can be very competitive. It could be a dog-eat-dog world where each person is out for themselves. And what we learned is that they actually needed each other. They needed collaboration instead of competitiveness. And then also just entering the field with a more holistic approach to what is needed to become a physician in the future, and how to meet those needs. There are generational differences with what an emerging physician values are compared to my generation and other generations. And so there are generational divides there, which is at the root of a lot of the harm and trauma that I address as a consultant.
Thanks very much.
Lisa, I think we'll have time to briefly answer your question if you want to try to come on camera, but and then I'll have to share something with the group, but it looks like you can do it. Yay.
Yes, perfect. Thank you. Yeah, I kind of wanted to check in. I feel like I work with a lot of people. I'm at the Burlington Restorative Justice Center or Burlington Community Justice Center. And I feel like I work with a lot of people who have kind of felt like they weren't being heard, or their symptoms weren't being taken seriously. And it's a lot of the people that I'm working with are people that have mental health diagnoses. And I notice a lot of the time things tend to be passed off as anxiety, and they're just told, oh, it's just anxiety, talk to a psychiatrist. And then a lot of them have found out that it's more than that, after going to several doctors. So I just wanted to kind of check in on, like, how do we help the healing with that?
That brings up two things for me. One is, I'm glad you said it this way, and it's not a criticism that you said the way, but like, that's just anxiety. Like, anxiety is real, and it causes real physical alterations to your brain chemistry, to your body, and going to see a psychiatrist is important for many people, or a counselor. During the COVID-19, I thought I had a counselor for the first time. It was just too much for me to deal with, having a young kid and going through COVID and working as a doctor. So I want to hopefully destigmatize that broadly, and I hope that we all can proclaim that. And I think that's an important step. And then I am actually hopeful. I'm looking at medical research now that the one silver lining of COVID, and especially long COVID, which I think is part of what you're referring to, is going to uncover more of the biochemical pathways that are leading to these things. And maybe we have misattributed things like chronic fatigue syndrome or fibromyalgia and those other kind of vague pain or other syndromes as more psychiatric and less biophysical. And I think we are starting research now, and there is more funding for research now to understand that, because there are more people going into that cohort of patients feeling that because of long COVID. So that's one silver lining I do have some hope for. So that's my 2 cents on that one.
Lisa, I just want to piggyback on that and say, yes, anxiety is real, but so is implicit bias. And we do not treat Black patients' pain and Indigenous patients' pain. We don't believe them when they tell us they're in pain, and we don't manage it in the same way we would treat a white patient. That is also true. And that's part of why these patients are feeling anxious about whether or not their symptoms will be believed. That requires a level of cultural sustaining practices, cultural humility, and that's all part of how we educate the healthcare workforce to be sensitive to manage their own biases and their own positionality and their own awareness. And there's a restorative way of doing that without alienating anybody and making that a reality, even in today's context.
So
Thank you both so much.
Thank you for your question, Lisa. Unfortunately, I feel like we could keep going for another few hours, but unfortunately we're at the end of our time. But I wanted to share one thing with the group. So if you enjoyed today, just hold on here. I just wanted to share with you that the Vermont Law and Graduate School does have a graduate program in restorative justice. So we have a master's in restorative justice, a joint degree in restorative justice where you can also study law and get a JD. We have a master's in public policy where you can focus on justice reform. And then we have some other sort of lighter weight offerings if people want to get just a little bit of graduate education. So these are some emails here that you can look into. I direct the graduate program in restorative justice, so you can certainly email me if you're interested in restorative justice type questions, or our admissions team if you're interested in learning more about that. So I'll leave that up for just a second in case people want to jot down those emails. But what I really want to do is thank our two amazing speakers today. What a privilege to have an hour with you to learn from your experiences. I really do feel like medical professionals have been some of our true heroes in recent years, and we're so grateful to have learned from you today. Thank you for all the participants for coming, and we hope you join us at the next healing series. I'll be letting you know when we schedule that. So thanks everyone, and have a great day.
Thank you for having us.
Be safe, everybody. Take care.